working with the Lwala Community Alliance. This is my 10th year in Lwala. So we journeyed along with the Lwala Community Alliance from the time when it was like a boy to now it is growing almost to a grown-up organization. So my role, as I mentioned, is basically to ensure that the health facilities are well positioned to meet the demand of the people within the community. So we do a lot in the community through the use of the community health workers, volunteers, promoters, whichever name. And once they create demand for health-seeking behavior, we ensure that the health of the hospital, the dispensaries, the health centers are able to give that quality healthcare services to meet the need for these people. So that is my role. I ensure that that is going on. We started with Lwala Hospital. We test the change, and then we scale. Once we have seen that this is something which is scalable, we are able to scale, and that's why we have been able to scale from Lwala Hospital. We moved to Rongo sub-county with 10 facilities. We moved to Awendo, Nyateke, 61 facilities. We are now implementing in 214 facilities. The models which we have tested and proven that these are working. Our model is community-led health model, whereby we put the communities first. Because they understand their problem, they know their solutions, so we support them to implement these solutions so that they can work. So in terms of the implementation approach, we work towards ensuring that every child celebrates their 5th birthday. As you are all aware, a child is highly likely to die before their celebration of their 5th birthday. So there are a lot of interventions, they name it immunizations, all that, so that they can thrive. We also work towards ensuring that these children have their mothers through ensuring that we have safe births, safe deliveries. During pregnancies, through antenatal care access, the mothers have a lot of challenges. So we reduce those barriers so that we can reduce preventable maternal deaths. For example, you will realize that women die because of postpartum bleeding. That is bleeding after birth. That is the major cause of maternal mortalities. We have come with some of the models where we are able to manage these mothers to reduce these mortalities. We also, once they are able to die, that golden minute, immediately a baby is born. For the pediatricians in the room, they will tell you that there is a golden minute. A baby is born, not breathing, they need resuscitation. You don't do it, they die. So we have interventions which are targeting that golden minute immediately after birth, called, the approach is helping babies breathe, the neonatal resuscitation. So we are able to support these babies to breathe so that we migrate them from that through the neonatal period, to the under 5 and all that. Those are some of the approaches which we do. Now, for the ones which now come with complications, the sickle cell, we came up with the non-communicable disease clinic. We started it in Lwala, where we are targeting the NCDs, sickle cell, the hypertension, the diabetes. So we have managed to reach quite a number of children. Some of them are already accessing routine clinic within Lwala. Some of them are, I can call them one time, because they come from other catchment areas. So we also link them to the nearest facilities. Because patients who come from, say, Homa Bay County, you diagnose sickle cell, you start on treatment. Because of distance, you may not link this patient to continue accessing care within Lwala, but we now link them to the nearest facilities like Homa Bay Referral, Rangwe, and all that. So we have diagnosed quite a number because it is one of the areas where we have prioritized. North Kamagambo, for example, is having high burden of sickle cell children. There's a time I was telling Robert that it is something which we need to have a study on, why there is higher number of children with sickle cell. And some of the theories which were coming is that because of intermarriage between the North Kamagambans, where you find they intermarry themselves, and sickle cell is hereditary. True or false? True. So if within the same family, the same community, where the problem is, it is an hereditary disease, you intermarry yourself, it moves from one family to the other. That is one problem. So as we are programming for sickle cell disease in Rongo, be rest assured that the number is continuously increasing because of that one intermarriage within the people of the same community where the problem is already there. So what is it that can be done to reduce this? Those are some of the, so that even as we manage, how can we reduce the number from increasing? I don't know that, whether it is possible to reduce. Can we stop that intermarriage? Yeah, those are some of the problems which I realized as I was directly implementing within the same community. So, at Lwala, we have different programs which are targeting these people. One of the key problems for the NCD patients, one is the cost. It is not well resourced from the county government. The cost in terms of even the diagnosis, the cost in terms of even the monitoring, the cost in terms of even the treatment. The drugs are high costly, and even the continuous travels to the health facility. The complications, a child with sickle cell, they complicate anytime. The crisis, blood, anemia, the pains. So that's on and off referral, because at some point we may not be in a position to manage them within the hospital. So we need to refer maybe to another facility for further care. That is one problem which these people are facing. The second one is stigma to the family, because for sicklers, even how they thrive is different from the other children. So in a family with high number of, with many children who are sicklers, you find that maybe with the complications, the protruded abdomen, the weight loss, all those ones make this family to be stigmatized of even bringing their children to the hospital. So that also makes the management very difficult because of the stigma working with them, home, hospital, and all that. Education. Many absenteeism from the school, now making them not to access education as other children. They go maybe 3 days, the fourth day, the pain comes, they are rushed to the hospital, they stay in the hospital 3-4 days. So you will find that they go to school 1 week, the next week they are not in school. So their performance compared to the other children is very, very much different. So you will find that an aging child is still in low grade, while the same children are in the higher grade. So they even become more stigmatized even in school, alongside many other problems which are affecting these families who have the sicklers within amongst them themselves. So if we are able to team up together, bring our efforts, we are able to look into which other ways we are able to support the people living with sickle cell disease, so that at least they can also see their future. Otherwise, thank you very much. I'll give it to Robert to sum it up in terms of the Lwala as an organization. Thank you.
Thank you, Cliff. I arranged us in this order because I don't have all that information that you've had here. So we are grateful to be with you this time to share with you what we can do together. We appreciate the partnership we've experienced so far through Pastor Collins and his team. We have seen cases that are being referred to Lwala. It was a surprise to us when we first started taking care of just 1 or 2 boys who were in our neighborhood. And then slowly we began to see these numbers increase. They increase, until finally we said, hey, let's start a support group for this team. And he has been kind enough with his team to ensure that any children who are seen in the community who have conditions that may indicate possibility of sickle cell, that they refer them to Lwala to come there for help. And so we are grateful that we can work together on that. As we first mentioned, Lwala's goal is that no one is left behind. No one is turned away because they cannot afford care. We charge a fee. Those who have insurance, they make some payment. But if a child shows up at the facility, they don't have money, parents don't have money, or a woman comes in labor and no money, no one is turned back. Everyone is treated. And this is why Lwala's last year in September, we launched the Lwala Endowment Fund, knowing that we do have many of such cases that will continue to show up at our doors and we don't turn anyone back. And so all the children, all the under 5s who come to Lwala, they receive free care. All the mothers who come to give birth, to deliver at the facility, they get free service. We do not charge for those services. Then UNITA and her team, they ensure that this mama, preconception, all the way the baby is born until they are 5 years, they are followed. Every month, we have it on record that if they do not show up in the clinic, then we ask her to give an explanation. And they will go with the team. She will follow up with pastor and find why is this mama not in the clinic. Maybe she's troubled. Maybe, family had issues, so they are not there. So basically, we have ensured that that loop is complete. To the facility where now they'll be meeting Dr. Chad there, and then he can refer back to the community, follow-ups. So nothing is just dropped and left there. The challenges, as we first mentioned, one that I would say that probably a combined effort would be, how do we assist if we have to make a referral outside of Lwala? Because when they come to Lwala, we support that service. But when Lwala has to refer them to another health facility, now we have very little control there. And we cannot force other hospitals to not charge them a fee. So then they might be asked to pay. Some of the efforts we have done for some of the identified critically needy families is to make payment for a small health insurance cover, which is about 5,000 shillings a month, to cover for a family. That covers the mother, the father, the mother, and the children as long as they are under 18 years. So the very needy families that we have seen, this will not afford, this family will not afford that care in case they need external help on a referral. So we would pay for some health insurance. But we are not able to do for all of them. We encourage, if they can, to raise some money, pay for their own insurance, As long as they come to Lwala, they receive that free care. We support blood donation campaigns in the county. We discovered that if we just do that for Lwala, it does not help us. And so Wycliffe and the team started a program where they are able to track blood availability within the county, and at the same time raise awareness in the communities how we can donate blood to support the needs of our community. So then Lwala supports that campaign effort, not just in Lwala, but we support that effort in Kuria, in Migori, in all the sub-counties. So then the county government, Ministry of Health team, they organize themselves where they conduct these blood campaigns, and then Lwala comes in and gives some financial support where they get blood donations from colleges, schools, and even in the markets on specific days, so that we are able to keep the target. So if we have a child in Lwala that needs blood, in our system, our lab person just checks the blood type, and they check in the system which hospital has this blood, and they make a call, and then they are able to transport that blood to the facility. So any support in terms of partnership, in which ways we can make sure that these things happen. Cost of drugs, Wycliffe has mentioned, that is increasingly high, and we want to keep supplying the medications when need is there. We have issues with importation, taxation, getting clearance. So if we get a way out of this situation, perhaps that will change things for us, but other than that, we just have to buy at cost. Testing equipment, and this is not just for Lwala. If the partner facilities that Lwala works with, they are able to also test, and we identify these cases wherever they are, so that we can support. The idea is not just us in Lwala, but how do we support this community of the situations that we see around us. So mine is just to encourage us. If there is a way we can continue to work together on that, our doors are wide open to ensure that no sickle smeller in our community is left behind. And that's our pledge, that we will continue to take care of it, no matter what. I think it's only fair that I leave it there. I talked so much about Lwala. I hope you don't want to hear more of Lwala's history. We spoke last time. But if you are interested, maybe after the break, I will be available to do that. Yeah, thank you so much.
Thank you so much for that clap. Thank you so much. Let's give it another one as they go back to seat. And Team America, we say to you, Karibuni tena. Let's tell them. Karibuni tena. Let's tell them again. Karibuni tena. Welcome back again. I would like to introduce one of us, Team USA, Janice, my grace lady, our only own, Mia Robinson. She's a sickle cell warrior. She has a lot to say and to speak today. Let's give a round of clap as she comes. And let's clap until she reaches you. Let's clap until she reaches you. Thank you. Now Mia has a lot to say. Let me give her the microphone.
I want to take up the time because we want to go shopping. First, on behalf of sickle cell warriors all over, I want to thank the medical team for treating us with compassion. That's something that we lack, unfortunately, in many encounters with the healthcare system. So I really appreciate that on behalf of warriors all over. And I personally want to thank you all for just checking in on me to make sure I'm okay, make sure I have water, make sure I'm resting. You guys have just shown me a lot of compassion and love, and I really appreciate it. My role, wherever I go, is to really empower people with sickle cell disease. When Tybo was trying to remember my name, he said, Mia, missing in action.